Welcome to the August edition of the ASC Journal presentation. Thanks to those of you who were participating in the Twitter chat last night and kept the discussion very lively. I am Dr. Rezai, the current chair of the eJournal committee, and will be moderating this session. Dr. Sayeed is a member of our committee and will present the chosen article. She is the director of Cytopathology Service as well as Cytopathology Fellowship Program at VCU Health in Richmond, Virginia. And her main lines of practice are cytopathology and GYN pathology. We are very grateful to the authors of this wonderful paper who accepted our invitation to participate in this very interactive presentation. Dr. Sayeed will introduce the authors at the start of her presentation, and not that they need introduction, as they are well known and respected in the world of pathology in general and specifically in cytopathology. In the spirit of our interactive presentation, we encourage your participation through questions and comments that are forwarded to us in the question box. And we will usually allow about 10 minutes or so at the end for the discussion. With that, I will turn the virtual podium to Dr. Sayeed for her presentation. Thank you.
Thank you so much, Dr. Rezai. I'm Sadia Sayeed. I am a member of the eJournal committee, and I'm very excited to bring this really great article to you all in the audience. Those members of the eJournal committee are tasked with finding a publication that really speaks to us that we think would be a great one to share with our ASC membership. And I came across this article and it spoke to me because we in our laboratory were thinking about the same idea. And so this article called One Procedure, One Report, the Reimagined Cytopathology Task Force position paper on small tissue biopsy, triage, and anatomic pathology is authored by many of the people who are on our panel today. So I'll let everyone introduce themselves. And this article was published in JASC, Journal of American Society of Cytopathology, just earlier this year. So Dr. Rezai did a great job of introducing me, but I am currently a cytopathologist and GYN pathologist at Virginia Commonwealth University in Richmond, Virginia. And I would like just to kind of go around to our panelists and they can give a brief introduction. Let's start with Dr. Amy Lee.
Hi, I'm Amy Lee. I'm a cytopathologist primarily, but I also sign up breast and thoracic surgical pathology and have been practicing for over 10 years. I chaired this task force and it was really great to work with people across the country. And I'll let Ron go next.
Hi, I'm Ron Balassanian. I'm Director of Cytology at UCSF and also sign out some breast service as well, and have been practicing longer than Amy, but don't want to admit how long, and very thrilled to be here. Thank you. 20 years. I'll pass it on to Dr. Pitman.
Hi, I'm Martha Pitman. This whole paper stemmed from my theme of my presidency when I was president of the American Society of Cytopathology. I'm at Mass General Hospital and past director of the cytopathology lab, and I'm thrilled that this paper has gotten so much interest, and I'm looking forward to the webinar. Cool. Go back to Susan then.
Hi, I'm Susan Alperstein. I'm a cytologist. I'm the supervisor at the Papa-Nicolau Laboratory of New York Presbyterian Weill Cornell, and I also serve on the executive board of the ASC.
Hi, I'm Mike Thrall. I'm at Houston Methodist Hospital. I'm the Cytopathology Fellowship Director here. I got involved in this largely because I helped put together the survey that appeared previously from the ASC about small biopsies and incorporating those into cytology practice. So I'm happy to be part of this panel today, and I'm looking forward to the presentation.
Hi everyone, I'm Lisa Zhang. I'm a cytopathologist and also sign out gastrointestinal pathology at Mass General Hospital as well. It was really my honor to be included in this group and on this paper. I recently was a cytopathology fellow at Mass General, so I got involved and was able to offer some perspective from the trainee side.
Awesome. Well, thank you so much to all of our panelists for being here. I really am honored that everyone is here, and hopefully this audience participation and the discussion with you all will make this paper really come to life for our viewership today. So briefly, the objectives for this talk will be to determine the utility of unification of these reporting of small tissue biopsies in anatomic pathology. We want to evaluate the advantages and challenges to implementation of this integrated approach to reporting results from single procedures. And finally, we want to examine how the application of this integrated workflow affects anatomic pathology and how it can be achieved in various practice settings. So I do have a number of poll questions for the audience, and these were taken from the paper that Dr. Thrall mentioned about this ASC survey, and we thought it would be a good idea to poll our audience to see maybe if some of the responses are different than they were in this publication, or basically who's out there, who's in our audience today, and how is their practice run. So I think we'll give maybe 30 seconds or so and see the audience response to these. So Joanne, can I see the final polling results, or does that happen after the poll is over?
Hold on for a second. The first question was, what is the relationship between the cytopathologist and surgical pathologist? So I don't think that's your correct question.
Should be, let's see. Well, that's fine. I think we can use that one, and maybe we can go in the order that
we can come back to it. You didn't give, I don't think I have one that's what the audience is.
Stop.
Well, maybe we can skip that one and come back to the second question.
Okay.
The question is, it doesn't have to do with who's in the audience. They're just questions related to the survey, the ASC survey.
Okay. So you want me to go ahead and move on to question 2?
No, you can go ahead and put on question 1. So most of these questions were taken from that ASC survey, so they're just sort of asking questions about how various practices function in terms of the cytopathologists and surgical pathologists, and how small biopsies are dealt with in the practice.
I don't see the poll. It shows up and it vanishes fast. Is that only me, or everybody else is seeing it? Hopefully other people can see it.
Yeah, we can't see the poll question.
Yeah, it just comes and then it vanishes right away.
Yeah, it's not for some reason letting me. It won't let me share that question.
Interesting. Okay,
First
it doesn't
question.
like that one. Well, why don't we continue and we can try again with the next polling question.
Sounds good.
All right, so we're going to move on, and we are going to get into the introduction and offer a little bit of background about this position paper. So as many of you in the audience know, that there is a volume increase in concurrent multi-site small tissue biopsies, and they're typically used to diagnose and stage patients with lung cancer. For example, FNA, core biopsy, transbronchial biopsy, they may all be produced from a single procedure on a single patient, and reporting the pathology findings for all of these sites during one procedure in one integrated pathology report is likely advantageous. So patients often undergo biopsies from multiple sites, especially in the thorax. For example, in EBA's procedures, you may have cytology samples such as direct smears, liquid-based preparation, cell blocks, and BALs. Histology samples also may be collected, such as core biopsies, transbronchial biopsies. Sometimes we get forceps biopsies as well, and you may have samples from several lymph nodes, as well as sometimes the actual pulmonary lesion itself. So here's an example that was given in figure 1 from this paper about how a sample report that is integrated may look. So here's an example of where the procedure would go, and it would sort of encompass all of the various samples that are collected, and then the samples are listed here, A through H, from all of the various sites, and the type of specimens are listed here, and the diagnosis would go in the same order in one report. So this is given as a sort of a generic example. So question for our panelists, were any of you using this type of integrated reporting prior to being asked to be on the task force?
Yes. We have morphed over the last 35 years that I've been at Mass General Hospital from splitting them to giving them different numbers in cytology and surgical pathology, but being interpreted by the same cytopathologist because they were generally true cell blocks. And then the core needle biopsies got bigger and therefore became more of a turf battle between cytology and surgical pathology. And just based on the size alone of the core would be split from the specimen, which really started creating the problems in integrating reports from a single procedure. And I think brought up the whole issue of, you know, who was best to look at these specimens, the cytologist, cytopathologist, the surgical pathologist, and then with the complicated processing, workup, ancillary testing, molecular testing, particularly in lung biopsies, and the expertise involved from a specialist even added to the demand for subspecialty surgical pathology interpretation of at least the core biopsies. So with that complex background, it was really an issue of, you know, how do we keep these together? We split them for a while, but, you know, when I was president, I really wanted these to be one procedure, one report, because it was best for patient care. And it was best for efficiency and lack of waste of tissue. You know, you wouldn't have redundant ancillary tests. So that was the whole basis. And then Dr. Thrall did the survey the year before I was president, and I was involved in that project. And then it brought us here today.
How about Dr. Balassanian or Dr. Thrall? Were you using integrated reporting in your practices?
I wish.
Yeah.
I think it makes a lot of sense. We have not been able to implement this degree of integration here at UCSF. But as someone who spends a lot of time working with patients to help them understand their pathology reports one-on-one, this makes much more sense for the patient, who's really the ultimate person that we're reporting to. And it's difficult to convey when the fine needle aspiration biopsy is reporting a different result than the core biopsy, or even more complex, I think, is when the fine needle aspiration biopsy of the same lesion is reporting the same diagnosis with different wording than the core biopsy. And then you have to say, well, these are both the same thing, but they're saying it in different ways.
Yes, I would echo that, largely for technical reasons having to do with LIS and so forth. It's actually, there are some difficulties in doing this, but I agree with everyone that if you can do this, it has a lot of good features to it, and especially you know, not just the patients, but also whoever is doing the procedure. It just makes it so that they don't have to try to sort through reams of different paperwork and correlate reports. I mean, what we do at Methodist, we still have different reports for the cytology and the surgical pathology. But what we do is we make a comment saying, you know, but you know, on the cytology reports, we say, you know, please also see the corresponding biopsy number, whatever. That way, at least they're alerted to the fact that there's another report out there for the same patient from the same procedure, but it's not as good as this, where it's all together and unified and organized in a single report.
Yeah, so we'll talk about some of the maybe challenges and advantages of this system as we go on through this presentation. So a little bit more background. So as you probably recognize, consolidating the pathology findings that are taken during one procedure would prevent the clinical team from having to review multiple reports, as Dr. Thrall mentioned. And sometimes there can be confusion by discrepancies in separate reports, and that would also be reduced, if not eliminated, if there was only one report to deal with. And this is a big issue, particularly in my lab, but the Cures Act enables patients to have immediate access to their pathology results, which is new, and published data has shown that many patients often review these results, usually through an electronic portal, prior to being contacted by their clinical provider or ordering physician. So issuing one pathology report would likely be less confusing to these patients for interpretation. And as mentioned before, this ASC survey that Dr. Thrall and Dr. Pitman spoke about was found that there was a lack of consensus on whether concurrent cytology and histology samples during one procedures are reported together. There's no dominant workflow across institutions, especially with regard to accessioning, triage, and grossing in AP laboratories. In some practices that are subspecialized, the cytopathologists and surgical pathologists often share responsibility for diagnosing concurrent specimens. And oftentimes there can be variable communication between the cytopathology team and the surgical pathologists that are reviewing concurrent specimens. And this could lead to inconsistent review of colleagues' materials. So here we go, another audience question. Let's see if the poll works this time. All right, looks like it's working. Okay, so this question is about how your laboratories function when it comes to small needle core biopsies. Who signs them out at your institution?
I think you maybe need to add a caveat here. When it is associated with a cytology component is really the key question. Because if it's just a core biopsy by itself, it goes to SurgPath.
Right. And I apologize, I had to shorten a lot of these questions. It only allows for 130 characters in the stem, which was really difficult to condense, but yes, thank you.
So I'm clicking on a button and it's not working.
I think it's just for the attendance only. I guess I thought that you're part of the panelists, but I don't know.
Thank you.
No cheating, Martha.
Okay, so you have to forgive me. This screen is really small on my panel, but it looks like the most popular answer is all signed out by subspecialty surgical pathology, I think. Okay, so we have a lot that were very similar, about 20% of the audience. So it looks like a pretty even split. Seems like the least common was all signed out by cytopathology. So that's interesting. That's actually how we do it in our practice here at VCU. Okay, all right. So after the background, just getting into the methods here. So ideally, to assess these various pathways to achieve integrated reporting for concurrent cytology and histology samples, this task force was convened called the Reimagine Cytopathology Task Force. And it was made up of various pathologists, many of whom are here now. And they were drawn from 7 academic medical institutions across the US and composed of some cytopathologists only, some that were surgical and cytopathologists, and some that did surgical subspecialty sign out as well. So a question for Dr. Pitman, how did you choose who was in the task force?
Well, that's a good question. Well, I started with the chair, who is Dr. Lee and my colleague here at Mass General. One, she's a very competent pathologist and surgical pathologist, and 2, she's right outside my office, and I would be able to collaborate with her from soup to nuts on this project. And then Mike obviously was involved in the survey, and he was a natural person to have on the committee. And then Ron and Ed were both great cytopathologists and surgical pathologists, and people who were responsive to work. You know, so people who did what they said they were going to do and in a timely fashion. And then Cindy, who's not here, is just a cytopathologist and not a surgical pathologist. And then Aliyah, who's not on the call as well, is a surgical pathologist and not a cytopathologist. So we had that diversity. And then Amber and Susan were our cytologists. It was very important to have the voice of the cytologist because they're such an important part of the workflow in both options in the paper. So that's, and then Lisa, as she said, she's a junior staff here and was recently out of her training and offered, you know, the perspective of a trainee, which was also an important part of the paper. So I thought it was a good, and then all over the country, right? It was a diverse geographical distribution and practice setting.
Yeah,
So
exactly. Okay, so there is an explanation for how the task force came to be. And looks like the task force recommendations were arrived by consensus of its expert members. And the proposal is of 2 pathways, and the 2 workflows or pathways that were produced by this task force were called the cytopathology approach and the surgical pathology subspecialty approach. So we're going to talk about this in a little more detail because we're going to refer back to this for the rest of this talk. But the cytopathology approach, in this approach, the cases are triaged to cytopathology, and cytopathology would initiate and drive the specimen evaluation and diagnosis, and they would likely request some input from a surgical subspecialty colleague when needed. And in the surgical pathology subspecialty approach, this is where a subspecialist in surgical pathology would review and diagnose all of the samples, including concurrent cytopathology and histology samples, and without the support of the cytopathology service. So this is a really nice figure that nicely demonstrates these 2 approaches. So if Dr. Balassanian, maybe you can take us through this figure and walk us through it a little bit.
Sure. So we were charged by Dr. Pitman to reimagine how we do this. And we really wanted to unify the workflow from the beginning when the specimen is grossed all the way through the end and draw on the expertise of everyone along the path of the specimen to the final report. So the cytopathology approach sort of mirrors what is traditionally done. All specimens, as it says, are accessioned to cytopathology and processed, and you can divide it as the cytopathologist reviews everything, and then you get consultation from surgical pathology, or the cytopathologist just finalizes the report. And that's sort of a traditional approach that's done in a lot of places. But as part of this, the thought experiment that really is this paper, where we all met multiple times and said, well, what if, how would we do this? We also wanted to see what could we do with just a completely unified surgical subspecialty approach so that cytology is then enfolded into surgical pathology. So that's the bottom scenario where all the specimens are accessioned to surgical pathology and then combined in a cytohistology lab, and then the subspecialist finalizes all the parts. As we're moving in surgical pathology to subspecialty sign out, one thing that's been across, many labs are moving towards, there's breast pathology, there's lung pathology, GI. Cytology has sort of been left out of that process. And so this was a way to say, well, how could we incorporate cytology into that? And there are a number of obstacles to making that succeed.
Exactly. Well, thank you. Yes, we're going to sort of continue to talk about these 2 approaches, some advantages and disadvantages, and really sort of illustrate some of the finer points of each of these workflows.
Could I make a comment?
Sure.
Add on that when you accession all the specimens together from one procedure, one of the things that becomes easier for an accessioner is that they don't have to decide whether something goes to cytology or something goes to surgical pathology. And this is becoming more and more of a confusing area because these small needle biopsies, they're getting smaller and smaller and more fragmented. And sometimes it becomes very difficult to tell the difference between something that is a cell block and something that is a small needle biopsy. This is occurring particularly with needle sizes around 21 gauge, 20 gauge, where you're getting very fragmented tissues that even a surgical pathologist would potentially hesitate to diagnose because they would look at that and think this is a cell block. But from the accessioner's point of view, it becomes a lot more streamlined. There's no question, everything just goes to one specimen, one case number. And we've, in the literature, called these small samples cell block compatible biopsies. And it is to reflect that there is this gray zone that is occupied by these increasingly small fragments.
CBCB, right, Mike?
Yes, that's right, the old CBCB. I hope that catches on. I like that acronym.
Yes. Very good point, Amy.
Yeah, it's always hard to look at what's accessioned as a cell block and really try to figure out, is it actually a core? What did they actually collect? So we have that same issue all the time.
And
Yeah,
in
when
fact,
when you get to the specimen review phase as well, you're going to have a spectrum of comfort on the part of a cytopathologist looking at tissue or a surgical pathologist looking at fragmented tissue. So then if you have everything together, then you can review the parts, all the parts, and ask for a second opinion when you are feeling like that would be useful.
I was just going to add that part of our SOP for triage in the grossing room, whether it's the histology bench or the cytology bench for processing, is if you can pick it up with a forceps and measure it, then it is technically a core biopsy. But if you can't do that, it's a cell block.
Yeah, I also was introducing the term along with CBCB of inforceptible, meaning you can't pick it up with a forceps.
I love that.
So I would also add quickly that this is another place where the cytologists have a role potentially. You know, one thing I would suggest if you are trying to implement a workflow like this is that maybe you should just have all of these things sent to cytology instead of to the histology lab. And then the cytologists can look at these and help to decide about how to accession them. That's another factor here.
They're also cytology. If it's a cytology-based procedure that has both components, it all comes to cytology and it gets triaged from our cytology lab.
Yeah, that's what we do as well.
Yeah.
Yep, same at our institution as well. So we're going to talk about sort of some of that processing that happens on the front end and the next couple of slides here. So the results of this task force were separated into the impact on various areas of the lab. So the impact on accessioning, triage, and grossing, the impact on reporting and diagnosis, impact on the cytologist or cytotechnologist, impact on trainees. So we're sort of going to discuss those various areas and what the potential impacts would be of this integrated reporting style. So we're going to start with talking about some of what we've already touched upon about accessioning, triage, and grossing these types of samples in one laboratory in one place. So I'm going to show a figure that outlines this a little bit better, but ideally the samples would be accessioned together for one patient procedure at one time. And this would require likely minimal training to familiarize the accessioners with the types of specimen parts and billing codes and case assignments that maybe they weren't used to seeing. In the cytopathology approach, this would be assigned to the cytopathology team. In the surgical subspecialty approach, the case would be directed towards the subspecialist surgical pathologist. And really, this would also simplify the clinical team management of the samples because they wouldn't have to send it at multiple places in the laboratory. All of the material would go to one location at the same time, and the person who's reviewing the samples can look at the material side by side to determine, okay, this one looks like this would be better for flow cytometry rather than having to wait and wonder what is the other sample showing. Additionally, the pathologists and clinical care team members would also be able to see right away that, hey, this sample is from this case, which was collected from this patient late on Friday, and they can see all of the parts all together rather than waiting for another part to come out on Monday that was received at a different laboratory at a different time. So this is a nice figure that demonstrates some of the various steps that could be involved in the integrated reporting style and how the accessioning would work with that. So maybe Susan could walk us through this figure a little bit and show us what you'd like to highlight from here.
Sure, I'd be happy to. So the roles of cytologists are expanding, and as they're expanding, you can see from this chart that in every process of the case, pre-analytical, analytical, all the way up to post-analytical, the cytologist can play a role in making the diagnosis more efficient for the ultimate sign out for the pathologist. So we talked a little bit about grossing, but we can also correlate areas, select ancillary tests, select the best material, and really screen, which is the most important, and correlate and make sure everything is efficient for final sign out. So I would encourage everyone to review your process flows and see where you can add your cytologist to help out with making a smoother transition for your sign out.
Great, thank you. For our other panelists, are cytologists in your laboratory working in these variable roles in your labs as well?
Some of the roles we are, and we're looking to add some more in the future.
How about the other panelists? Are the cytologists doing things outside of the normal realm of what we expect them to do in your labs?
Definitely in our lab, we're finding new roles for the cytologists, more engaged in the specimen collection at the time of rapid on-site evaluation and determining what to do with the core biopsy and so forth, as well as report preparation too, in terms of looking up history and procedure notes and so forth. So I think cytologists, with the name cytologist implies them as a engaged physician extender and less as a technician working simply in the laboratory screening. So we're trying to explore ways to expand those roles for them.
Yeah, some of the cytologists in our lab will also review ancillary tests, namely GMS stains or IHC stains. It's not a regular routine occurrence, but I've noticed that there are some individuals who are very interested and motivated, and they will just look at it. And so they have definitely a skill set that we can take advantage of. There was a prior paper as well that came out of our institution that looked at training cytotechs, we're now cytologists, in reading prostate core biopsies. So this is, I think, a real opportunity for that profession.
I think also there's some cost-effective benefits as well to reduce the costs and have the pathologist focus really on just signing out. And I just want to add that we do screen our AFB, GMS, and special stains. The cytologists do that tedious work and enter the diagnosis in the LIS.
I think that's one important point to make, at least in our institution, as long as I've been here, our cytologists screen our non-GYN specimens and put a preliminary diagnosis in the LIS, which our trainees can see and they can then reflect on what the cytologist says. And I'll tell you, I respect our cytologist opinion dramatically. I mean, to the point where I will stop and show another pathologist if I disagree by more than a little bit. Saved me more than once.
I totally agree. Same at our institution. I trust them inherently, and they've been interpreting some forceps biopsies, and I'm really proud of the learning that they're doing on histology. They've been doing great. So I'm really encouraged by their additional skill set that they're learning because we have integrated some of our surgical path specimens with cytology. So as we sort of discussed, some of the impacts on potentially integrating your workflow towards one reporting system would be increased efficiency. So more staff may be competent and confident to perform these tasks within cytopathology especially, and this would reduce the risk of samples being lost in transport. If your cytopathology lab is in one place and your surgical pathology lab is in another place, for example, and cross-training personnel always gives the ability to operate under critical staffing shortages, which we know nothing about, right? Just kidding. Cross-training also is a benefit because employees can grow competency in their staff and increase their job security and employability. All right, time for another audience poll question. Let's see if it works again. There we go. Okay, so this question is about what percentage of cases go to that have small cores, again, probably combined with a cytology specimen, go to surgical pathology, and how many of those is a cytopathologist consulted prior to sign out? So if this is your practice, then it has some answer choices, and in your practice, if surgical pathologists do not sign out small cores, you can just choose the last answer choice. So the question is about how many times or what percentage of the time does a cytopathologist get consulted when a surgical pathologist is looking at a small core? Oh, okay, so it says less than 10%. All right, so that looks like by far the most common answer. So people are ignoring the cytopathologists. We have good skills. I'm just kidding. So we'll get into a little bit why that could be the case. And please feel free to enter into the chat if you have a reason or why you answered that way and why you think that might be the case. Okay, so now talking about the impact of this integrated reporting on specimen review and diagnosis. So we mentioned this at the beginning of the talk, but there is an increasing trend towards subspecialty in surgical pathology, and this is very strong across multiple institutions. Published data argues that case review by a subspecialized pathologist in cytopathology and surgical pathology improves diagnostic accuracy when compared to a general pathology practitioner. And using either of these approaches allows for the subspecialized pathologist to identify discrepant findings and gives the opportunity to resolve them before issuing the final report.
We are not seeing your screen, your PowerPoints.
Uh-oh, I'm sorry. Let me see. Oh, how about now?
Back up.
Okay. There we go. Okay. So now you can see it, right?
Yes.
Okay, perfect. Sorry about that. So again, the diagnostic workups can be minimized when you have one report because it allows the ability to do biomarker testing and really preserve that tissue for the various tests that need to be performed, especially on lung cancer diagnoses. So when evaluated separately, if you have a cytopathologist and a surgical pathologist that are working on the same diagnosis, they may unnecessarily consume the tissue in two parallel workups, for example. And so if you had concurrent review, it prevents this redundant testing and can be more cost effective, especially for IHC and molecular testing. And sometimes if an individual sample has a low number of tumor cells for molecular testing, you may be able to combine some cytology and histology samples to achieve that adequate cellularity for molecular testing. So cytopathologists are typically also surgical pathologists and often are comfortable diagnosing core biopsies and larger tissue samples, but perhaps the opposite is not also true. So we're going to get into that in the next slide. But cytopathologists are also very comfortable with cytohistologic correlation, as this is something that we're doing, especially on a retrospective basis as laboratories. And we're reviewing histology samples because we're performing cytohistologic correlation on a monthly basis. So subspecialty surgical pathologists who do not undertake this practice, they may be less comfortable with interpreting cytology as they're not consulted on cytology samples for correlation purposes. So in the cytopathology approach, it allows for a subspecialty surgical pathologist to also review a case if needed. So the cytopathologist would review all of the sample types, including cyto and surgical pathologists. Pathology, they would render the diagnosis, and they can then share the case with a subspecialist surgical pathologist for their opinion. The cytohistocorrelation would occur then in a prospective manner, and hopefully the discrepancies, if there are any, would be resolved between the specimen parts prior to reporting, making it easier to interpret. But this does require some coordination. It may increase turnaround time for issuing final reports, especially if the two pathologists are not in close physical proximity. And you may need some admin assistance to help support this increased frequency of slides being transported. But it was mentioned that digital scanning of the slides could be a possible solution. So I'm curious to ask our panelists, are any of you in the digital pathology workflow? Do you have whole slide scanning?
We're using it for.
We do not routine.
Go ahead. Go ahead.
Go ahead, Ron.
We just have it for core biopsies and cell blocks, but we're not at the point where we're digitizing smears. But now there is no excuse for at least the cytopathologist to know what the concurrent core biopsy shows. And we are finding that the residents are very engaged in this. They check everything before they come to sign out. So sometimes it's the next generation that advances the field, and the older pathologists don't want to be left behind. They're like, oh, the FNA shows something. Let's look at that too.
Yeah, clearly there's still some issues with scanning smears and liquid-based slides, since there's that three-dimensionality that sometimes doesn't get adequately represented or captured on scans. But we do not have routine scanning of slides for anything related to cytology yet. Maybe this will change in the future, but we can hope.
Involved in a lot of the new scanning and digitization here at MGH. What is your perspective as a young pathologist? You hear me, Lisa?
Oh, sorry, I didn't hear that you were addressing me. I think you were breaking up a little. Yeah, I think unfortunately in our department currently, our scanning is mostly used for education purposes, and we haven't really had the staffing and I think the investment in bringing it beyond that for more clinical use. I'd really love to see that one day, because I know that there are many institutions across the country now that have really advanced scanning to more of a clinical stage, but currently we don't really have that. I would say that with regard to scanning, I think it's really useful for trainees to have experience looking at digital slides, because one example is for our board exams, including cytopathology boards, everything is scanned now, including whole smears, liquid-based specimens. And so I definitely remember when taking my boards relatively recently, I was, for example, not as used to scrolling through an entire ThinPrep slide on my screen very quickly. So I think in the coming years, definitely it will be important for everyone to get more experience with looking at digital slides.
I think with increasing telepathology in the format of rows, which is way very widely distributed at this point. That has been, I think, the major exposure to digital cytopathology that we've, most of us have had some exposure to as well.
Yeah, I mean, in fact, most of our rows now is with telecytology, but it's not, it doesn't replace signing out the case by looking at the glass slides.
Yeah, we have the same experience at our institution. I think it's not integrated into our workflow, but it can definitely be very useful, especially in this type of a situation where you need a concordant case to be reviewed by another pathologist. Maybe they're in a different building, maybe they're working from home. They can very easily see and agree with your diagnosis or resolve this potential discrepancies. So definitely a potential solution for the future.
It is coming, no question about it. That's the future. It's just not here yet. You know, but there are places in like Scandinavia that don't use microscopes at all.
I know, I've heard about them. Their computer desk is a computer, no microscope. Like, how do you know they're a pathologist?
Oh. We'll catch up with the radiologist soon enough.
All right.
We are scanning our smears for tumor board presentations, and I'm finding that's a very effective way to get pathologists familiar with looking at smears digitally, which is different. It's more portable, but it is a little slower to scroll through a slide on a screen, and you just have to get used to that. So
we're also using telepathology for on-call. So if you're at home and you have a rush on a Saturday, now I don't have to commute in an hour to go look at a small biopsy of colitis. I can do it from my screen at home.
Yes, definite advantages for all of us. We could probably talk about digital pathology for a long time. There's a lot to say about it. But in this paper, that was definitely one of the aspects of a solution to some of the challenges with integrating and condensing results. So back to some of the differences in the two different approaches. So in the surgical subspecialty approach, this is where the surgical pathologist, again, would review cytology samples, and maybe they're not all sufficiently trained in cytopathology. There's likely a heterogeneity to cytopathology training across the land, and for various pathologists at different stages of training. There may be a bias for those surgical pathologists towards reviewing just the core biopsy that they may be more comfortable with, and only a cursory examination of cytology preparations, especially if the cores are the good diagnostic material. So here's another opportunity for a cytologist or a cytotechnologist to provide some support and additional training to those surgical pathologists. So they would be a valuable resource here. Potentially quality measures such as cytohistocorrelation or risk of malignancy calculations could be another way to assess how the surgical pathologist performance is going. And it may be helpful for laboratories to try a trial of a new workflow from a small subset of cases to see how it works before implementing changes more widely. So with this workflow, which sounds very progressive and maybe radical to some of our audience members, in our lab, we just had a minor change, which is we combined the forceps biopsies into our cytopathology reports. And that was a minor change, so it didn't really affect too much of what we do, but it was a big change in terms of reducing the confusion from the patient standpoint and for resolving some of this discrepancies between surgical and cytopathology. So it made a really big impact, even though it was a small change. So I know we're running short on time, so let's do one last audience poll question. All right, so this question is, in your practice, if your small tissue cores that are associated with a cytopath case go to your cytopathologist, how often are the surgical pathologists consulted prior to sign out? So it's sort of the opposite of the last question. So You're a cytopathologist, you're assigned small tissue cores. How often are you showing your surgical pathologist's colleague on those cases? Okay, so the most common answer is less than 10%. Okay, so kind of similar to the last response. So it looks like not as much sharing. Okay, let's move on. We have a few minutes here left, and I want to leave some time to get to and some of the chat questions, or if the audience has any comments for our panelists. So a few other points that in the diagnostic reporting side of things, the cytopathologists, they tend to use more structured reporting formats. Now, this is not true across the board, but in most practices, there is some sort of diagnostic line that is reserved for one of those more uniform reporting styles. For example, in the Bethesda thyroid, you would have diagnostic categories such as benign, atypical, suspicious, etc., in addition to more narrative diagnoses. And when issuing an integrated report, you can have the diagnosis reported separately, including some of these more combination of this structured reporting. So here's an example of that. So in this example, figure 4, all of the samples from the pancreas and liver are combined. So the diagnostic line says adenocarcinoma, but perhaps there would be more of a structured reporting, for example, a drop-down menu that would say the diagnostic category, but then the final diagnosis would be more simplified and just say adenocarcinoma, because that is the most important diagnosis first, and it's very easy to see these 3 samples had adenocarcinoma and this one was benign. So a little bit more on the diagnostic reporting. So on the cytopathology approach, the cytopathologist would use some of the structured reporting style, and then the surgical pathologist may then add in some of their free text diagnoses for the histology components. So nothing would change much in the reporting workflow in that example. In the surgical subspecialty approach, because the surgical subspecialist may not be familiar with this structured reporting style. Again, this would be a good place for the cytotechnologists or cytologists to be a resource to provide some of that guidance and training if needed. So figure 5 is another example of how reports can be condensed or combined so that they can show the most important information first. And this would, here's an example of that. So in this example, specimens 1 and 2 from the pancreas are combined into one diagnostic line here, and it says adenocarcinoma, and the mismatch repair results here. And the liver, the 2 samples, one was benign and one was malignant, but in the end, the combined diagnosis would be adenocarcinoma because they're both from the same specimen source. So here's another example of a more condensed format. And again, if there was more structured formatting here, it may be something that's visible to the pathology lab, but maybe not necessarily to the patient or to the clinicians. So impact on patients, we talked about the Cures Act and the availability of immediate results, often through an online portal. So the integrated reporting would reduce this barrier of patient literacy because all of the diagnoses would be in a single report, and it would be helpful because the patients might not realize how many different biopsies are collected during one procedure. So if there's diagnostic discrepancies, hopefully it'll be easier to interpret what the final diagnosis is. For the clinical team, so subspecialty review is likely going to be very valued by the clinical team members, who are often the colleagues that are leading and discussing tumor boards, and it would improve communication between the pathologists with the subspecialty colleague. In the cytopathology approach, if there's a conveyance of malignancy risk through the structured reporting, that could be very valuable. And then oftentimes it's mentioned here that free text comments or narratives may not be read, or maybe not read as carefully by the clinicians. And depending on how various pathologists word their reports, they might be difficult to interpret. So overall, it should enhance the efficiency of our clinical team members, because they would have an integrated report. They would have to look only in one place to see all of the results from the procedure and be able to hopefully understand what the report says, because it would be all in one place. Impact on pathologist workload calculations. So this is another important point, that if these two systems were implemented, they may have more consultative review with another pathologist. So it would encourage the pathologists showing each other cases, especially a surgical and cytopathologist, to work together. And how would this be documented? How would this be evaluated to see this potentially extra work that a pathologist would be doing? So multiple systems for workload calculations, for example, RVUs, don't really take into account interdepartmental consultations. So sort of food for thought, how could this be incorporated, and how can we keep track of this potential added task of additional consultative review? We're going to skip this poll question in the interest of time.
Very good. We have one question and one comment, so it would be good whenever it's good for you to stop. I'll just bring them both to the podium.
Perfect. Thank you.
Right. Sure.
So we touched upon this earlier when we were talking about the workflow, the impact on cytologists and cytotechnologists. So these team members uniquely have the ability and skill to provide prelim diagnoses for pathologist review. In our institution, they are going on site and doing rapid on-site evaluation on their own, oftentimes without telepathology. So they're really a great a member of the team and really help our pathologists do what they need to do. So increased participation by our cytotechnologists and cytologists would be advantageous for both approaches here. We gave several examples of how throughout this presentation. So this expertise in triaging and assessing a variety of small tissue biopsies. They could provide training for a surgical subspecialist who may be less comfortable with cytology cases and sample types. And it could help expand their role to provide growth in multiple areas and help promote their opportunities, which are critical for workforce retention and watching the evolution of cytologists in the workplace. And lastly, the impact on the pathology training and education. So both approaches would benefit the education of pathology trainees, because it would help them concurrently review cytologic and histologic samples and grow that cytohistocorrelation skill. In the cytopathology approach, definitely for the cytopathology trainees, they would be engaged from early on with looking at the on-site evaluation and then comparing those results to the final diagnoses in this integrated format. For the surgical pathology subspecialty fellows, they would also receive training from an expert surgical pathology attending and likely be able to compare their own cytologic interpretation with those rendered by the cytopathologist. There are a few potential downsides, which are, as we discussed, increased potential turnaround time and shepherding cases back and forth between attendings on multiple services. And this could be stressful if that's your role as a trainee, is that you're the one responsible for currying these cases around and showing them. Additionally, the surgical pathology attending would have to be competent to teach cytology to the fellow, and in addition to the histology, be able to evaluate that trainee's performance with regarding how they're interpreting the cytopathology. And in the example of having that surgical subspecialty approach, where maybe a cytopathology attending is not involved in the process, the cytopathology fellow would have to sort of garner their knowledge in various areas by rotating through multiple subspecialty services to satisfy the ACGME requirements of the number of specimens that they're required to review per year. So in summary, there are several advantages to an integrated pathology report. Likely will increase the overall diagnostic accuracy. It allows judicious selection of samples for appropriate ancillary testing. It reduces barriers to prospective cytohistocorrelation. It can produce more comprehensive and cohesive results for physicians and patients. But as the panel has discussed, there's no one-size-fits-all solution, but even small and stepwise modifications can help achieve this type of reporting system. So it's important to establish a workflow expectation and get agreement or buy-in from all of the parties involved in the various specialties to really successfully implement this type of workflow.
Very good. Thank you very much. I'm just going to have the questions first and then the comment if the time allows. The first question, I think you kind of brushed upon in your last 2-3 slides, and it's from how is this affecting training for cytopathology fellowships? It would be difficult to track cases with cytology going to various surgical pathology subspecialties.
I think this would be a great one for Lisa's perspective, to hear her perspective as someone who's recently graduated.
Yeah, so during my fellowship was sort of when we transitioned to having the integrated reporting for our thoracic specimens, and it definitely was had a transition period where there was more time required on the part of the fellows to take cases back and forth. We do spend just as much time reviewing the cytology portions of the case when we receive them as the fellow, and we also have that added benefit of also reviewing the core biopsy specimens alongside at the same time, which can be very helpful. And then I think in terms of the actual training, it takes a little bit more of an individual motivation to, I think, follow the specimen to the end. So from my perspective, I would actually keep a running list of all of the pulmonary cases that came to me, because eventually I would give the case to our pulmonary pathologist subspecialist, and then they would sign it out, and I would need to follow up afterwards to see what ancillary studies they did, what the results of those studies were, what the final diagnostic sign out is. So I think in that sense, there is a little more burden on the trainee to follow up with cases to get the full learning potential out of them. But I think the upside to that is that you get to see all of the parts together. So sometimes I would pull the slides once it's signed out to review it all and see like how they arrived at that final diagnosis, see all of the stains they did and things like that. So I think in the end, as long as you are motivated as a trainee, it can really improve your knowledge of that surgical subspecialty.
Yeah, I'll jump on the end of your statement and say that I totally agree. And I think that having the cores be together with the cytology specimens is actually an improvement over what traditionally would have happened, which is you'd have an FNA and then you wouldn't even know there was a surgical core, or the surgical core or excision would come much later. And so you didn't even have the opportunity to intellectually think about what stains would you order? What is the morphologic correlate from the cytology to the histology? Whereas now you are getting that. You're still not getting the final diagnostic report, but you actually have an opportunity here that didn't previously exist. And there would be there's no difference between looking up the case now, in this integrated manner versus the way you'd still have to look it up in the past, which I think that is a valuable thing for all fellows to be doing anyway.
Add that we have come to this agreement with our pulmonary subspecialist only for cases that are primary lung cancers. So for the fact that we have kept all parts together, there are many, many cases that we as cytopathologists keep and sign out entirely on our own. So it's only the primary lung cancers that we've agreed to triage to our specialists.
And it's been really good to have that done, because we've had, I personally have had cases where the cytology portion was reviewed first and it was diagnosed something like non-small cell favor squamous cell carcinoma, and then it went on to the surgical pathologist who applied some stains and ultimately turned out to be an adenocarcinoma. And so they were able to revise the discrepancy, address the discrepancy before sending out the final report and having to avoid an amended situation or confusion on the part of readers.
Exactly.
Very good. Thank you very much. I have one more question. If you use the surgical pathology subspecialty approach, then don't you still need to have a cytologist screen the cytology part of the case because of the CAP workload regulation for screening non-GYN cases? Because otherwise the surgical pathologist would need to document workload and cytologists do because they would be screening the cytology slides. So I will leave it open for the discussion.
Yeah, there's not much discussion. The answer is yes. You have to document who is reviewing these smears. So if you're a cytotech, cytologist screening, then you have to document that workload. And if you're a pathologist who's doing that, you also have to document that workload. So yeah, that's just going to be standard expectation.
That's why you keep your cytologists, and they're an integral, important part of the team.
Very good. No, that's perfect. Makes perfect sense. I guess the question maybe wanted to say, would the cytologist still screen and send it to the surgical pathologist or no? And that's, I think that was the bottom line of it, which again, I think that's a yes from where I am sitting and where I know, but I just wanted to bring it up to the, everybody here. So I think the questions are done, and we had one comment earlier on, which is basically what it has been talked about the whole time throughout the session. And it would be saying, it would seem to me that a combined approach would also help save diagnostic material for tumor markers testing without two pathologists working up the same case, which I think we have said it in so many ways and so many shapes. And I think that ends our question and answer part. I just wanted to say thank you to everybody who participated on my behalf, and I know Dr. Sayeed will say the same thing. It is wonderful when we have the authors participate in these presentations. That just brings a different level for discussion and a lot more engagement. Thank you very much for your time. I'll leave it back to Sadia to say her last words. And
yes, thank you so much to our panelists. I'm really honored that everyone was able to join in this discussion today. I certainly learned a lot. I continue on this journey towards integration at our institution, but this is an incredible recommendation, and it's great to hear how various pathologists are practicing this integration at their institution. So thank you so much for being here today. I really appreciate it.
Thanks for choosing the article.
Very good. Thank you very much. This was wonderful.
Yes, I think if the attendees, any of them have questions, any one of us would be happy to contacted by you if you have questions or just want to discuss, ways that you could do this in small or large steps.
That sounds great. And usually we ask the audience if they thought of questions later on, or there was too many questions that we couldn't get to it, they send it to us and we'll forward it to you guys, and that way, or they can directly reach out to you. But regardless, hopefully that will help not to have anything goes by the wayside. Thank you. Thanks again.
Bye.
Perfect. Have a wonderful day. Bye-bye.
Bye.